Well, welcome to UOA On Demand. Today, our topic is minimally invasive bunion surgery. My name is Justin Fleming. I'm a foot and ankle surgeon with University Orthopedic Associates, and I'm joined by the newest member of our orthopedic group, Dr. Kevin Schafer. Kevin, welcome. We're really excited to have you on board.
Thank you, Dr. Fleming. Happy to return back to New Jersey. I'm a Monmouth County native and have been doing my training in different places like St. Louis and Baltimore, but very happy to come back to New Jersey and do what I love and take care of patients.
That's great. So does that mean, are you a Jets fan or a Giants fan? How does that?
Giants and Yankees.
Giants and Yankees. Okay. Well,
non-negotiable.
I think the audience is going to want to know where you stand, whether you're a good guy or not a good guy. So, well, great. Kevin, you've learned from some really great surgeons at your time in fellowship in Baltimore. Share with us a little bit of what your fellowship was like and how did you get into minimally invasive bunion surgery?
My fellowship was a really special experience. I trained with 5 foot and ankle surgeons who only do, foot and ankle surgery. A bunch of the more common bread and butter things like big toe arthritis, and ankle fractures, very common injuries, but also some of the more interesting cases, very complex arthroplasty or joint replacement procedures, very complex deformity cases. So I was very fortunate to see a very broad spectrum of pathologies and learn how to treat all of them. So I'm happy to bring that skill set back to New Jersey and start working up here with UOA.
That's great. And again, we're just excited to have you on board. So just for the audience, there maybe is some confusion about the terminology when we say a bunion. So just tell us in the most basic terms, like what is a bunion and how do those patients present with symptoms?
It's kind of a catch-all term that really just means an angular deformity of the big toe. It's drifting over towards the lesser toes. We do see some patients sometimes that tell us they have a bunion and they don't. They have big toe arthritis. But it really is just an angular deformity. It can be due to a number of reasons, and it's usually different in each patient. It can be because they have a strong family history. It can be because they have looser soft tissues. It can be because of an old injury. We may not know why they have a bunion, but it's important to understand each patient's foot, both on examination and with imaging, so that you can understand how you can treat it.
Right. And so tell me, what are the things that people would do before they have surgery? Is there, what would you recommend for someone who's starting to have some symptoms now?
Sure. I think it's always a good idea to try to avoid surgery if you can. Although minimally invasive surgery has a very low risk profile, a lot of our surgeries have lower risk profiles. It's not zero. So we can get away with treating someone's pain and symptoms without a surgery. That's a win too. So common things are trying wider shoes, shoes with a lower heel, modifying some of their activities. If you spend a lot of time up on your toes, whether it's doing jump rope or something like that, where you're loading your forefoot a lot, cutting some of that stuff out can really help. So those are really the first interventions in trying to get away with a non-surgical treatment.
Okay. So let's say that I've gone through all of that and I'm still having discomfort, who then is a candidate for surgery?
Sure. It's really the patient who has pain and deformity, as long as you're talking about bunions, that has tried reasonable measures such as modifying their shoes and their activities, and it's affecting them, on a regular basis. It's affecting their ability to walk, to exercise, to really be comfortable in shoes, which affects everything you do. And those are the patients that we sit down and have a discussion about the surgical options so that they can get their life back.
Okay. So in kind of broad terms, when we say minimally invasive surgery, I think people may think of like laparoscopic surgery and things like that. And so tell us what minimally invasive surgery, what a bunion looks like under those conditions versus kind of a traditional open approach. And how do you determine who's eligible for MIS or open surgery?
Minimally invasive surgery is interesting because a lot of things about minimally invasive surgery are very similar to the traditional bunion corrections. We're really doing a lot of the same things. We're cutting the bone, we're shifting it, and we're holding it in place with usually just screws. You can use plates, not in the minimally invasive setting, but so all of those aspects of the treatment are really the same. What's different is how we're doing it. So, in a traditional open bunionectomy, as you know, you're making a reasonable size incision so that you can expose the bone that you want to cut, so you can protect the important surrounding soft tissues and nerves and vessels, and then cut the bone. But in minimally invasive surgery, we have this little tiny burr. I don't know if you can see it here, Justin, and I'll hold up a pen next to it just so you can get a gauge of how small it is. It's about 2 millimeters in diameter, but you really just need to make a poke hole in the skin so that you can introduce that burr to then cut the bone. In terms of who is a candidate for that procedure, and it's really a surgeon dependent discussion. There are some folks who are a little bit more aggressive with minimally invasive techniques. I think if you're a little bit more conservative, it's definitely someone who has a more flexible joint, because what's unique about minimally invasive surgery as well is it's an extracapsular procedure. So to do what's called an osteotomy or a bone cut in an open setting, you're usually having to take down the joint capsule so that you can do it. But in a minimally invasive setting, we can avoid going into the joint capsule, which we think is beneficial for promoting better postoperative motion and faster healing. So those things are a little bit different, but definitely patients who are good candidates have deformities that are more flexible rather than deformities that are very, very severe and very, very stiff.
So you mentioned some of the advantages. Just give the viewers a sense of why do you do minimally invasive surgery? What are the benefits to the patient who is able to undergo minimally invasive versus a traditional procedure?
Obviously, the minimally invasive part, right, smaller incisions, is cosmetically pleasing. That's one advantage. What's been proven in multiple peer-reviewed studies has less postoperative pain. We know that the pain scores will go down faster with minimally invasive surgery. There was one study showing that patients took on average about 2 oxycodone pills after surgery. So we know, definitively that it does allow patients to experience less pain after surgery. There is some evidence supporting that patients can recover faster. You're not doing the traditional open exposure where you're stripping some of the soft tissues off the bone, and those soft tissues have blood supply, so the bones can heal faster, and the overall recovery can be faster.
So we're talking about maybe less OR time, smaller incisions, which produces less soft tissue inflammation, so patients get less swelling, and potentially there's some opportunity for the bone to heal a little bit quicker, right? If we're leaving all the necessary blood supply intact.
Right.
I know that you have a case that you'd like to show, and I think this is a great illustration. So maybe if you could share your screen with the viewers and maybe just describe what it is that you're showing.
Sure. All right. So this is a case that I participated in this past year where you can see the patient has a bunion deformity or an angular deformity of the big toe. The toe is pointed this way towards the lesser toes. You can see that there's a little bit of splaying characteristic to the first and second metatarsals. This is the surgery that we did, the minimally invasive surgery, where we cut the first metatarsal across. We shifted the metatarsal head over this way to give a much better alignment of the big toe. And we held that in place with these screws. These are also put in through small poke hole incisions. So it does look a little strange to see the bone shift over that far, but here's an x-ray showing that actually your body does a great job of remodeling and healing the shape of that bone, resulting in a great appearance of the foot through those little small incisions.
Well, that looks tremendous. Give us a sense about after surgery, are these patients allowed to weight bear? What are the restrictions? How quickly do they get back to activity? I think those are things that are commonly asked questions.
Sure. Right after surgery, patients can bear weight on their heel. My recommendation is they do that for the first 2 weeks. After that, they can put full weight on their foot in a protective shoe or boot. And I keep that on for about 6 weeks, just because we are still cutting the bone, we're asking it to heal. That being said, you're not in that shoe all the time. Starting at your first postoperative visit at 10 to 14 days, you're taking that off and you're working on range of motion so that you can start to get that toe moving so that when your bone does heal, you have good motion. After 6 weeks, we start to work you into a normal shoe. And really, you're increasing your activity from there. The slowest part of the recovery for some patients is holding back on the impact activities. Patients who are runners, especially, we recommend they wait probably at least 6 months, just because if they're really getting after it before then, they may experience some swelling, which can produce some pain. But you're putting weight on it right out of the operating room, at least on your heel, and we're pretty aggressive at advancing it from there.
So does every patient need physical therapy? Can they do some things at home? What do you recommend?
Yeah, most patients don't need physical therapy after this procedure. Certainly, there are some who benefit from a little guidance, especially if they have a stiffer toe in terms of working on motion a little bit more aggressively. But a lot of patients, it's really just getting back into walking and starting some lighter activities like biking and going from there and letting pain and swelling be their guide. A lot of patients don't need to go to formal physical therapy.
So one common question that I get asked all the time is, will my bunion come back? And
Right.
everyone knows someone who's had bunion surgery, right? And,
Right.
well, my cousin, she had surgery and then she needed surgery again. So what do we know? Or is it still an unanswered question about the recurrence rates with MIS versus kind of the traditional approaches?
Sure. Well, as you know, there's only one procedure that has a 0% recurrence rate, and that's a big toe fusion. But in a patient who has a very healthy joint and a ton of motion, they're not going to be happy with the fusion. That's why we're talking about doing a bunion correction. The recurrence rate, really, in the last 3 to 4 years, the literature has shown that it's just about the same as the traditional procedure. So there's really no increased risk of going minimally invasive with regards to recurrence. It's not like we're trying a new technology that doesn't have the same success rate. So from that perspective, it's safe and it's effective.
Kevin, you showed some x-rays that look great, and I noticed some big screws in there. One concern that patients often have is, are these screws going to cause a problem in the future? And do I need another surgery to take them back out again? What are your thoughts on that?
That's a great question. The screws that we're using now have a really special shape to them. The head of the screw is actually on an angle, so that when we bury it, it's really flush with the surface of the bone. So when we put it in, it's uncommon that we can usually feel the screw head from the skin. So a lot of patients don't even know that the screw is there because it's buried either flush with the bone or just under the bone. That being said, if you look at the literature, because this is an interesting topic as well, that a lot of patients are concerned about, it's about 5% of patients are bothered by their screw, whether they can just feel it or whether it backs out a little bit as the osteotomy heals. That being said, it's the recovery after a screw removal is much quicker. You can do it under local anesthesia in most cases. It takes a few minutes to take the screw out, and the recovery is fast where you're walking immediately. So it's not a huge deal, and fortunately, it's not very common to have to take the screws out.
Okay. So I do think that there is, when I look at gender differences for bunion surgery, I feel that we probably operate on more females than males. And perhaps that's shoe gear. And one of the things that I always get asked is, am I going to be able to wear any type of shoe afterwards? And so how would you respond to that question?
Yeah. The number one goal of surgery is to get patients out of pain. After that, trying different shoes. I'm not going to tell anyone they can't wear a certain sort of shoe. They may not find a high heel exceptionally comfortable, even after you fix a bunion. They can certainly try to wear it. And in those situations, they're probably going to try to wear it no matter what you say. But it's the point of the surgery is to help patients get out of pain. And if they can wear those shoes and get away with it, that's great.
Yeah, I agree 100%. And I do think the sweet spot is, really 7 to 9 months when the swelling is resolved. And,
right.
I think a traditional bunion, when we look at it, over the course of healing, the full recovery is probably a good 9 to 12 months. Do you feel like that's pretty much in par and in line with minimally invasive surgery?
Yeah, you certainly see parts of recovery out to that long. I will say patients are feeling pretty good and back to a lot of activity well before the 9 to 12 month range. But particularly in patients who do marathon running or a lot of heavy impact activity, that osteotomy or that bone cut, it has to heal together pretty solid. Otherwise, you can, like you were saying, experience some of that swelling. That's painful, whether it's walking or getting into a tighter shoe. So, patients certainly should be encouraged that if they're having some pain at the 6 to 9 month mark, that, we watch it a little bit longer, because there's a good chance that it's going to settle down.
Yeah, great. Well, Kevin, it was a pleasure, talking to you and just learning about your experiences. For those of you at home, if you're having foot and ankle symptoms, or just want to learn more about advanced foot and ankle care, please reach out to us at uoanj.com. Thank you.
Thanks.